he moved up and down and then it wasn't solid there. But that's one of the things we do when you go to the doctor and they're feeling or palpating your neck, they're kind of feeling for that gland. So, the hormones of the thyroid, T3, T4, that's thyroxine and triiodothyronine, what those are called. I'm going to use those interchangeably during lecture today. They are hormones secreted by the thyroid, okay? So if I'm talking about thyroid hormones, I'm talking about T3, T4. I kind of use them interchangeably. They are different though, okay? T4 accounts for about 90% of the thyroid hormone that's made from the thyroid gland, but T3 is more potent and has greater metabolic effects, okay? So just know that they're different, but I will probably be using them in a group as the thyroid hormones today, okay? So T3 and T4, can you all see this? Okay. T3, T4 are excreted by the thyroid gland. I apologize for my artwork because TSH tells it to. This is, what is this? Pituitary. Okay. That's the pituitary gland. The pituitary gland secretes TSH, thyroid stimulating hormone, to tell the thyroid, to stimulate the thyroid to release hormones. Okay? Does that make sense? I will refer back to that multiple times. Okay? And our body is in this constant feedback loop. Okay? It's constantly monitoring, and it's going to secrete more or less T3, T4 based upon what is needed. Okay? So iodine, we need iodine to synthesize T3, T4. Okay? So we need about 1 milligram weekly. About 80% of the iodine that you ingest is going to end up at the thyroid. So here in the US, do you think we have any issues with getting enough iodine? What do you guys think? No, why? Where do we get iodine from? Food. But what in our food? What is iodized here in the US?
Salt.
Salt. There you go. Yay. So we have iodized salt. Okay? Salt from the store is iodized. Even when you buy the non-iodized salt within, foods we buy at restaurants or pre-made foods that we have, there's other sources of that iodine. Lots of that around here, and that was done to avoid us from getting goiters. So that's that enlarged thyroid. We're going to look at some pictures of that in a second. So in this country, not typically caused by a lack of iodine here, but that can be a cause. Okay, so iodine's important for synthesizing T3, T4, but also too much iodine can actually ruin the thyroid or burn it up, and it can go the opposite direction. It can cause hypothyroidism. Okay, so it's one of those things. You can flip-flop, go one way or the other. We need an adequate amount of iodine to be able to synthesize T3, T4. Okay, so these thyroid hormones, like we said in the Kahoot, regulate nearly every function of the body. Metabolism, growth, all kinds of stuff, blood pressure. So in excess or deficit of these thyroid hormones, we are going to see those symptoms because of that throughout different processes of the body. You guys following along? Yes? No? Okay, good. That's good. Thank you. Okay, so this is just sort of what I drew up here. Calcitonin is on here. And just know, calcitonin is made in response to high circulating calcium levels. So it lowers the serum calcium levels by inhibiting the transfer of calcium from bone to the blood. You guys don't need to know a lot about it. Just know that that calcitonin is there. There's a few ways in which it acts. Just know that it's there. Really, there's no details that you need to know on it, okay, for our purposes today. Okay, so this is a goiter. So when I say goiter, I literally just mean enlarged thyroid gland, okay? It does not mean that there's any pathology related with it. There could possibly be absolutely nothing wrong with the thyroid. We do thyroid tests and we see that their TSH is fine and their T3, T4 is fine, but maybe they have an enlarged thyroid or a goiter. So it's possible to be what's called euthyroid, EU thyroid. That's how that's said. And that means that it's a normal functioning thyroid. So when you hear the term euthyroid, that's what that means. Normal functioning thyroid. Now if a patient has a goiter, they could have hyper or hypothyroidism. They could have some pathology related with it. There could be something going on there, but that doesn't always have to be the case. Okay, so some of the causes for a goiter, like we talked about earlier, lack of iodine, not an issue here, but in some developing countries, that is an issue. Goitrogens, now that's a fun one to say, but a goitrogen is just it's something that contains a thyroid inhibiting substance. So drugs such as lithium, amiodarone, those are two examples for you. Some foods, peanuts, broccoli, you can see a list of them on page 1328 in your Lewis textbook. Those are goitrogens. Now, does that mean that you don't need to eat broccoli because it's bad for you? No, but maybe too much broccoli would be a goitrogen. Probably not going to be a big issue for a lot of people. But know that there's such a thing as goitrogens, and that is anything that has a thyroid inhibiting substance. Okay, so a goiter could be caused by nodules, or it could be caused because these hormones are out of whack, they're unbalanced. So how do we diagnose a goiter? So we can visibly see, we can palpate a goiter, they can do ultrasounds to see a goiter, but if they want to diagnose if this patient is euthyroid, in a euthyroid state, or if they have something else going on, we're going to look at their TSH and their T4 levels. So we're going to look at the hormones to see if anything is out of whack with them. So to treat that, say they had hypothyroidism, and we'll get into that, but hypo, low, they have these low thyroid hormones, then we maybe give them thyroid hormone, right, a synthetic thyroid hormone, or we may need to do a surgery. So if this patient is euthyroid and it's not causing any issues for them, we're probably not going to go into surgery. Okay, so if it's getting really, really large and it's starting to compress on the trachea, or if it's giving us issues like it's secreting too much hormone, we can go in and do surgery and remove it or part of it. But if it's not causing any problems and it's just an enlarged thyroid, I'm probably just going to leave it alone. Just let it be. Okay. So this is a nodular goiter, very pretty picture here. So these patients, they have these multiple nodules on their goiter, you can see that, or they can have just a singular nodule. So it could be a multinodular goiter, or it can be a solitary autonomous nodule. So most of these are benign, but they're going to go test just to make sure that it's nothing malignant there. So how they diagnose this, again, we're going to look at the TSH and the T4. And then if the T4 is really, really high, the TSH is really, really high, they're going to go in, possibly move it, remove it. So these toxic nodular goiter can cause hyperthyroidism. And what happens there is these nodules themselves, they begin to behave independently of this feedback loop that's happening here. So a nodule within the thyroid itself is spitting out T3, T4. It's spitting out all these hormones, regardless of what TSH is saying to it. So TSH should be saying, knock it off, stop, we don't need more T3, T4. That nodule doesn't care. It's just going to keep spitting it out. Okay? So it acts independently. Okay. So different process here. Thyroiditis is what it says it is, inflammation of the thyroid. Okay? So this could be caused by a viral infection of some sort. It could be a bacterial infection, it could be a fungal infection. So whatever it is, it has an abrupt onset. Patients will have pain in their thyroid. They may not have any pain in the thyroid at all, but this pain could radiate to the throat, the ears, the jaw, fever, chills, sweats, fatigue, kind of what you think of as your run-of-the-mill virus, right? And it could cause thyroiditis. So sometimes we don't need to treat this. It's going to run its course. It'll be done. Now, if it's bacterial, we can treat it with antibiotics. But sometimes we may not even need to treat this at all. So typically, it's going to resolve within a few weeks or a month. It's going to be self-limiting. So tissue damage can occur. So during that sickness, tissue damage to the thyroid could occur, which could lead to hypothyroidism. So thyroiditis doesn't go away for everybody. Typically it does, but it can also destroy that tissue and cause hypothyroidism. So treatment for these patients. Antibiotics, like I said, if it's viral, if it's some NSAIDs and corticosteroids. Why might we need to give them beta blockers?
It can cause high heart rate.
High heart rate, yeah. So it can cause issues with our heart rate, it can cause issues with our blood pressure, but our heart rate, I talked about how the thyroid really controls everything, right? It has an effect on every system. So these patients could have hyperthyroidism, and now our heart's beating fast, or we have other symptoms, and we use beta blockers for those cardiac problems. Okay, so Hashimoto's thyroiditis. Has anybody heard about this? Yes, I have some hands up. Good. Okay, so Hashimoto's is hypothyroidism, and I'm emphasizing the O to help you guys remember. But Hashimoto's is autoimmune. I want you guys to star that, underline that, whatever you got to do in your notes. Remember that Hashimoto's is an autoimmune disease of hypothyroidism. Okay, so you have these anti-thyroid antibodies that are present, and they start to destroy that thyroid tissue there. So this is the most common cause of hypothyroid goiters in the U.S., but just because a patient has Hashimoto's does not mean that they're going to have a goiter. Okay? So what we're going to see on these labs, I kind of work this backwards in my head. So I don't start up here at TSH. I usually start out down here. Okay? Can you guys see this backwards? Okay. So this is T3, T4. So Hashimoto's is hypothyroidism, which means low. Okay? So our T3, T4 hormones are going to be lower. So what do you think TSH is doing up here? A lot. It's screaming. It's saying, hello, we need more T3, T4. Come on, come on, come on, come on, come on, right? It's pestering them. Lots and lots of TSH. That's like mom yelling at them constantly. Come on, come on, come on, let's go, let's go, let's go. We need more, right? This is mom yelling, saying, let's go. We need more T3, T4. So in a patient who has hypothyroidism, you've got mom here screaming, let's go, move along, right? TSH keeps yelling, doesn't stop, right? So my son probably talks about me. Keeps yelling, won't stop, because there's not enough of these guys. They're not doing their job. They're not getting their job done, okay? So we're going to have low T3, T4, and high TSH. Does that make sense?
Yes.
Okay. But the difference with our autoimmune disease is these anti-TPO, let me make sure I'm saying that right. Anti-TPO, these antibodies that are there. I think I'm saying that right. Okay, so remember Hashimoto's, hypo, low hormones. Okay? So let's step into hypothyroidism. So I told you a little bit about it, talking about Hashimoto's, but this is kind of run-of-the-mill hypothyroidism. And I say that very loosely. If you guys know somebody that has some sort of endocrine disorder, they don't all fit in the same box, right? I have some stories about my mom. She doesn't quite fit in the box. And so these can present differently in real life, but we're going to talk about the NCLEX hospital here where we're fitting in a box, okay? This is the NCLEX hospital. This is my perfect hypothyroid patient, okay? So if you know somebody and you're like, that's not what my mom had, probably not, but she's not hanging out in the NCLEX hospital, right? Okay, so hypothyroidism, low levels of these circulating hormones. So we're going to have what with these guys up here? Mama's screaming, right? High TSH. What is something that maybe could be lacking in my diet? Probably not my diet, but somebody's diet that maybe would give them hypothyroidism. They wouldn't be able to synthesize iodine. Perfect. They wouldn't be able to synthesize T3, T4. So that might be somebody who has hypothyroidism. So what causes this? So tissue destruction. So in the thyroid itself, there could be issues with the thyroid itself. There's tissue destruction, so it's actually not physically able to create T3, 4. So that is a cause of that. We could have an issue higher up here in the process where we have an issue with the pituitary gland. It's failing for some reason. Okay. We talked about an iodine deficiency. And then post-radioactive iodine treatment. So radioactive iodine treatment, this can be done for a patient that had cancer, This is also a treatment that's done to actually ablate the thyroid in certain situations, which we'll talk about shortly. But radioactive iodine treatment could cause hypothyroidism. And there are certain drugs, we talked about the goitrogens, so amiodarone, lithium, interferon, and some others as well, could cause hypothyroidism. Okay, we all together? Okay, so hypothyroidism, I want you guys to look at this friend up here on the screen and put him in your brain as your hypothyroid example, okay? So this friend, he is up here, he is shivering, he is intolerant to the cold. He has, remember, hypothyroidism, so everything is going to be low and slow, okay? So he's very tired, okay? Very tired, impaired memory. Sometimes I feel like I have hypothyroidism, so I'm like, somebody will come talk to me, I'm like, I don't know. Or the other day, someone complimented my shoes, I'm like, I'm wearing shoes, what? It was so weird. But sometimes I just feel like I can't quite process, right? Some patients with hypothyroidism feel that way. Anxiety and depression. They really just don't want to do anything. They'll be gaining all this weight and feel like, man, I'm not eating any differently. I'm not working out any differently. I cannot lose weight. And I'll tell you, after I had my kids, I think, I don't know, I probably didn't, but this is how I felt. It was like I was cold all the time. I was exhausted. I was gaining weight, of course, postpartum, but it just felt really hard. You're just stuck there, and there's nothing you can do about it. These patients might experience constipation. Why? Everything slows down, even GI motility. Okay. Let's see. Dry skin, hair loss for these patients. They just kind of feel achy and weak. Let's see if there's anything else here. Slow to speak. So kind of just think everything slows down. So when we get further into the disease process, we might see things like their temperature is actually going to be lower. Like their core body temperature might actually be lower. Slower heart rate. Weight gain, I don't know that I would say that's necessarily late manifestation. That's probably typically the one people pick up on the quickest is that weight gain. Thickened skin, cardiac complication, that comes later. So this myxedema, it's coming here. I've got a picture of this. This is just like this puffy, very like padded look in the face. And I've got a picture of it for you guys later. But it's just this look that they have. Okay, so to diagnose this, we can look at a thyroid panel. Okay, so same thing. We're going to have we'll go backwards. T3, T4, because it's hypo, is going to be low. We've got TSH up here, screaming, yelling, we need more T3, T4, so it's going to be high. Okay, is everybody following that? Okay, so remember, this is not to diagnose Hashimoto's. Okay, this is run-of-the-mill hypothyroidism. And, okay, here it is. The high thyroid antibodies, those are anti-capital T, capital P, capital O. That's how it's said. Anti-TPO is what, if somebody had Hashimoto's, the autoimmune version of hypothyroidism, they're going to see those anti-TPOs, and that's how that's diagnosed. This will be happening as well, but they will have that anti-TPO. Okay, so this is something, if you ever see a patient and they have low T3, T4 levels as well as low TSH levels, that is possible. I'm just mentioning this here. You're not responsible for knowing this. This is going to be a really, really critically ill patient, but I just want you to know that. So if you ever see that, you're like, that's not possible. It's possible. It's called non-thyroidal illness syndrome, NTIS. But it is possible, but it's not. You're not responsible for knowing that. Okay. So how do we treat these patients? What do you think this patient needs if they have low T3, T4? They need T3, T4, right? Right? Great. So we're going to replace the hormones. So this is a drug, levothyroxine. This is going to be the prototype drug. I want you to know this one backwards and forwards. This is a really, really good one for NCLEX to test on because it's really used quite a bit. Like I don't know that I had a shift that I had that I didn't have a patient that needed Synthroid. Okay, so we need to know that it increases the effects of anticoagulants. We need to know that it decreases the effects of digitalis. So digitalis has a really narrow therapeutic index. This is a medication for heart failure patients. So we may need to make dose adjustments because the levothyroxine might make it not as effective, right? It's going to decrease it in the body. Monitor for cardiac problems. Why might we do that if we're giving somebody levothyroxine?
It regulates heart rate.
What's that?
It regulates heart rate.
It regulates your heart rate. So if I had a patient who maybe had some bradycardia because they had hypothyroidism, we need to recognize that giving them a synthetic hormone, we could throw them in the opposite direction, right? So we've really got to monitor these patients closely. Which leads to, we're going to check their levels regularly. So levothyroxine has a very long half-life, like 6 to 7 days is the half-life of it. So these patients could take this medication for 2 weeks, a month, before they start to feel the effects of it, right? So this guy on the screen who was shivering, it didn't feel great, and he starts to take his levothyroxine, and like a couple days goes by, and he's like, what is going on? This isn't helping. Like, I'm still miserable. What's going on? It may take him 2 weeks to a month before he starts feeling those effects. So we're going to do run lab values in this patient 4 to 6 weeks after the initiation of the therapy. So we're going to initiate levothyroxine, and we're going to test about 4 to 6 weeks to check the levels. Now what's interesting, and what really stinks, is if we initiate this, the patient starts taking levothyroxine, they take it at the same time every day, and I don't know, 3 weeks into their therapy, they forget a day. And then they come in to have their lab values drawn, and you say, so you've been taking your medication every single day at the same time? They said, yeah, but there was this one day that I forgot. Guess what happens? We start over. We've got to start that 4 weeks over again before they can come in and test. Okay, so lots and lots of education points for these patients, which is why this is a really great question for NCLEX or for your exam. Okay, so again, we're going to take this every single day at the exact same time. Or we might have some issues with the effectiveness of the drug. So likely, these patients are going to be taking this medication for the rest of their lives. Not always the case, because our goal with most patients is to get them back into a euthyroid state. So not always is the case, but typically, these patients are going to have lifelong treatment. Especially if it's a hypothyroid patient, they need these hormones. So they're going to typically be taking them for the rest of their life. So they're going to start them on a lower dose because we are worried about throwing them in the opposite direction. So when we start them on these medications, they're probably going to be on a lower dose. And then at 4 to 6 week intervals, they're going to test their TSH levels, or T3, T4 levels, TSH levels, all the things, and make a decision on, do we need to up it or are we good? Okay? Very consistent. These patients must be very consistent. We need to ask the right questions. Not like, hey, have you been taking your medication, but have you been taking your medication every single day at the exact same time? So these patients also need to take this on an empty stomach. Okay? So we've got to teach them all these interactions you guys see up here: iron, calcium, aluminum, antacids, sucralfate, soy milk, okay? Walnuts, cottonseed meal, high fiber foods around the time they're taking that medication are all going to affect the absorption. Okay? So when you go in to give your 9 a.m. meds and you hand your patient a handful of meds, including their levothyroxine, their Synthroid, that might be a problem, right? Yes, that might be a problem. Because the other medications that they're taking with it are going to affect the absorption of it. So really these need to be taken by themselves on an empty stomach at the same time of day. And it's going to be a big teaching point for our patients. Okay? What about our patient that's on a tube feed? Might that be a concern? Yeah, that might be a concern. We may need to hold their feed for a little bit, give their medication, and hold the feed, and then start later. That was something that came up when I was first starting out on the floor, and I noticed it, and they're like, oh, we've never thought of that before. So, just something to think about. So, drugs that increase the metabolism of thyroid hormone: phenytoin, phenobarbital, carbamazepine, and norepinephrine. You guys have probably seen all of those this semester, or you're about to see all of them. Okay, so this is a side note. There is a drug called the Torix. It's the synthetic mix of T3, T4 in a 4-to-1 combination, and it has a really fast onset, so it peaks at 2 to 3 days, and so we can use that in acutely ill patients with hypothyroidism. Again, you're not responsible for knowing that, but just for your general knowledge. Okay, so I talked about that mixed edema look that these patients can have. This is, so for patients who have this severe, long-standing hypothyroidism, they'll have this look to them. It just looks very padded, the tongue gets really thick and very prominent. That periorbital edema, dull, puffy skin, coarse hair. So when we talk about somebody who has a mixed edema appearance, this is what we're talking about. We're going to talk about mixed edema crisis in a minute, and don't confuse the two. When you just say mixed edema, we're talking about this look. Okay, so mixed edema coma crisis. This is severe hypothyroidism. Okay, severe hypothyroidism, mixed edema crisis. So this is associated with a very high mortality rate. So this can happen to a patient who has hypothyroidism and they're not taking their medication. Or maybe they take their medication with a bunch of other medications that render their levothyroxine useless, right? So they're not getting the hormones they need, so then they're going to go into this mixed edema crisis. Okay? Infection can also bring this crisis state onto these patients. So infections can overwhelm the body's compensatory mechanism responses to their hypothyroidism and cause them to go into this mixed edema crisis. So signs and symptoms, severe hypothyroidism. So all the symptoms that we saw on our little shivering guide, compounded, right? All of those compounded, hypothermic. So we're not just cold all the time, we have a low core body temperature. They have that look to them, slow heart rate, low blood pressure. We may need to go intubate them, right? Because they're in respiratory failure. Hyponatremia, hypoglycemia. Okay, very confused, drowsy, may progress into a coma. Completely obtunded. So this is severe hypothyroidism. Okay? So for these patients, we need to make sure we're monitoring their heart rate, their blood pressure, get an EKG on them. Have them on the EKG, temperature, respiratory status. So IV solutions. So there's some IV thyroid hormones that we could give them. Okay, and then we're going to have to really watch for the signs and symptoms of synthroid toxicity or levothyroxine toxicity. Okay, that'd be throwing them in the other direction. All those low and slows are going to go high and fast. Okay, if they're hypoglycemic, obviously give them glucose. We're going to keep them warm because they have that lower core body temperature. So they're very, very sensitive to CNS depression, so we're going to try to avoid sedatives and narcotics with these patients. Okay, for the sake of separating the material, I'm going to let you guys take a brain break. Let's do 10 minutes. We'll come back in here at 2, and then we're going to go the other direction into hyperthyroidism.